All right, so we got a Dr. Caleb Burgess posted how to exercise when in pain. A
Yeah.
nice little meme or Instagram created post explaining like pain level on a scale of 1 to 10 or 0 to 10 rather. Minimal, acceptable, excessive is the breakdown. Modifiable factors, range of motion, exercise, body position, et cetera, et cetera. Essentially, he's saying, uh, how to train through pain, during pain, and then paying attention to what's acceptable, what are modifiers, and symptoms after exercise to pay attention to. And Dr. Ray is excited about this one.
Yeah, I mean, so here's what I think. I think the overall message is good, right? Because I think it's saying how to exercise when in pain, and it's basically I think it's decreasing the fear avoidance that people may get sometimes as well, right? Where they say, I'm having a little bit of pain, I'm going to avoid the gym altogether, and then I'm just going to kind of jump out of it, rather than assessing, okay, well, what have I done with my load? So I had a girl come and she hurt her back the other day, about a week and a half ago, and I said, well, what was the exercise? She said, well, we were doing 5x5s. I said, okay, and she said we were doing 5x5 deadlifts, but the prescription was 145. And I said, okay, well, what's your predicted 1 rep max? And I know there's some, we could go on about that as well, right? Going off percentages, but
So stop you right there. When you say prescription, like that was the prescription for everyone in the class, or
that was the wide prescription for people in the class.
got it?
And I said, well, how many times can you do 145? She said, I usually can only do it 2 to 3 times. And so I said, well, okay, well, maybe we learn how to, they've got a chart up. And I said, maybe let's talk about how to use this chart. I said, I know it's old information. It's been out there for a long time, but it at least gives her something to work off of.
Sure.
And so I was like, look, if you can only do 145 2 times or 3 times, here's your predicted 1 rep max. You really, for a 5x5, should be here. At least if you have nowhere, if you know that 145 is wrong, it at least gives you a better
Right.
guess.
Right. At least a shot in the dark, somewhere to start with.
Exactly. And I think that's what the message is good, is that, hey, like, here's some modifications, right? So if you scroll down in it, hey, range of motion, if deep squats hurt, try decreasing, or it tries to give you some recommendations. And I think the overall theme is, hey guys, like, when you're in pain, you can still work out.
Mm-hmm.
I think the message to the audience, depending on who the audience is, if the audience is a strength coach versus a consumer or just the average Joe that may be following him, or a physical therapist, I think all three would maybe take something different from this.
Sure.
Whereas the consumer, I think, would say, okay, well, as long as I stay within 0 to 3, maybe 4 to 5, and I don't have any symptoms afterwards, or they go down within 24 hours, then I'm okay, and I don't have to bring it up to anybody. I don't have to mention it. I don't have to say anything to my coaches. I think that's where we go wrong, is that the consumer says, well, I can just exercise through pain and I won't say anything because I saw this post. And that's an extreme view of it, right?
Sure.
I mean,
Sure.
the reality is, I think they had very good intentions with it, and I think it does. But we have to. I think a lot of times in healthcare, we have to say, well, what's the opposing view say, right? I tagged you in this. Well, what would the opposition say? Like, what's the opposition to this message? The opposition is, I think this just paints it with a really general brush.
Mm-hmm.
And again, I think this says, okay, when in pain. Well, are we talking? Is it tendon? Is it ligament? Is it cartilage? Is it nerve? And that's where I think this kind of takes it very general. It says the more likely scenarios, right? So maybe you strained your muscle, had a ligament sprain, or, had something going on with your tendon as well, right? So one of the above there, it doesn't necessarily apply to nerves. And that's where even some physios or physical therapists don't even know how to respond to that, right?
Right.
That's sort of, if you've had some more training in neurodynamics, then you may be able to respond to this better. I think, and I've got a couple other points to get to, but I'd love to hear your take on it from how you viewed it from the eyes of a strength conditioning coach and specialist and saying, well, here's how I view it and here's how I would apply it. But I think the intentions are good, but I'll probably, after you say your piece, get into a little bit more of why I think we could change it, or maybe give suggestions on coaches who have read this, or physical therapists who have read it. How can we make it better, or what other information can we give the patient?
Right.
Go for it.
Yeah. So what I took away from it was sending home a great message in terms of don't freak out, right? When something happens, especially when it's your first time, like we'll use the most common example just because everyone can relate, but when you throw out your back, right? Or when your back locks up, you did something, or perhaps you woke up one morning and you're like, holy cow, I can't move, right? And that's when pain gets interesting and super complex and way out of my league, and therefore I try to stay as confident and cautious as possible. Is the double C word that I use: cautious and confident, because 9 times out of 10, if we approach it right, there's nothing wrong. So nothing wrong in the sense that it tends to go away quicker when you approach it confidently and cautiously rather than lay in bed all day, right? And I think we can jump the gun by running to the doctor or something like that and saying there's something wrong and start catastrophizing, and then really messing up the mental side of the house and having the fear factor taking place. But a perfect example is, what I mean is by pain is extremely interesting is the fact that pain isn't always associated with something like structurally wrong, right? So just happened, I'll give 2 examples, one personal just because it was extremely recent. 3 weeks ago, went to bed completely fine, woke up in the morning, tried to stand up and fell over, like borderline paralyzed, like could not get off the floor. And fortunately, not to make it sound bad, but being a veteran at this, not in the terms of I'm always throwing my back out or anything like that, but it's happened to me before, right? So instantly, the logic side came over me, whereas somebody this might have just happened to who's brand new to the gym, right? They could have taken a completely different route with it, but I went in my mind as like, look, nothing happened while I was sleeping, right? I didn't miraculously, like have a bulged disc or something spewing out my sides. I took all the ridiculously irrational thoughts out of my mind. It's like, look, you're back locked up for whatever reason. And right now I need to move. I need to teach myself that there's nothing wrong right now, and I need to get up and I need to start moving, right? So literally on all fours for about 45 minutes, couldn't get up. Eventually stood up, started moving, started doing air deadlifts, because that's a smaller range of motion. So just literally mimicking a deadlift with nothing. After I got that moving, I started going squats, air squats, got that moving, was able to get to work, right? Pain didn't go away. I was just able to move now, right? I'm in pain. I'm locked up, if that's the term we want to use. But I'm moving now, right? Things are substantially better. And so immediately took that into mind. Like, yes, I'm sucking right now. Yes, I'm miserable, but I'm not stuck on the floor, right? I'm at the next step. And so the day went on, got moving more with work, went home that night, went to bed, and I'm thankful it didn't play out so easily because it makes for a stronger testimony, but went to bed that night, woke up the next morning, still locked up, still miserable, still tight. But I acknowledged that it was better than the first day, right? So got out of bed, same routine, just associated myself to movement isn't bad, this movement isn't bad, there's nothing wrong. Long story short, from the first day, couldn't get off my hands and knees. The day after the next, I was already back to my 400-pound deadlift for reps. So the point of that story is that we don't always want to catastrophize and take pain as like a bone sticking out of my body and there's something terribly wrong, right?
Sure.
Within 2 days, I was not only back to exercising, but with prescription loads, no adjustments, nothing. So very interesting, very complex topic that I just try to stay confident and cautious with, right? And that's not to say that when I went to the gym, I was like, F it, I'm going to push through the pain or whatever. I systematically made sure everything was fine. After every warm-up set, reassured myself, and took on the mindset that I'm going to stop wherever I can handle today, and that'll be it. And it just so happened that I was able to work up to my prescription load. The second story I like to bring up, and I'll make this one quicker so I can kind of wrap up my philosophy and where my mind's at, is there can be some traumatic looking incidences that don't really add up to a whole lot. So working an athlete, can't remember the details. I want to say we were working up to a 3-rep max. He was hitting some pretty consistent rep maxes. So what we call the acute chronic load ratio was in balance. This wasn't a spike on his body. This wasn't anything out of the normal.
Sure.
And this kind of goes to touch on another side of it, but everything was fine. Everything was in check, right? He came out of the bottom of the second or third rep, one of the last reps, and just screamed, ouch, dropped the bar, came crashing down. He fell forward out of the rack. I think it was like over 400 pounds on the bar, right? Looked very dramatic, very elaborate for good reason. I mean, he was in some pain. Fell down on the ground, started moving around, collected himself after about 2 minutes. It was more of just like a loud noise. Obviously, he strained his groin. And the first thing I do as a strength coach is, one, I stay in my lane. I'm not diagnosing anything. I'm not doing anything like that. My immediate response and my only response is caution and confidence. I'm like, look, man, let's look at you. You're fine. You're not. Nothing traumatic is happening. Nothing acute is happening that we need to go to the ER, right? There's not bones sticking out of your body. There's nothing dramatic. So my first thing is to like wipe out like the ridiculousness, right? Like, look, you're on the ground, you're hurt, your groin's strained, got it. Let's stand you up. Let's get some confidence back. Let's get you moving, right? So this was about a 45-minute process, and he stood up right after this happened. He was able to do some air squats. Load was painful, obviously. Like, we gave him a dumbbell to hold just to see what would happen. There's some pain there, so dropped the dumbbell, just did some air squats, got him moving, immediately got confidence back. Long story short, very serious strain that, again, had this happen to somebody very brand new, they probably would have rushed to the doctor. The doctor would have told him to chill out, gave him some pain meds, and that was it. Fast forward only 4 days later, and we were back up. We weren't at prescription weight, but we were back to his prescription weight was in the 400s during this cycle. We were back up to 300s for reps in the back squat. No adjustments other than the load, with no contraindications, no added strain, no pain, nothing like that. So the point of all this is I really like seeing posts like this because it promotes caution with confidence. We don't want to freak out. We don't want to over dramatize things. And quite frankly, there's more of me out there than there are medical professionals. So we don't need to be jumping out of our lane and start self-diagnosing and saying, oh, this is wrong, and start causing fear and all this stuff. We need to stay in our lane, confidence and caution. And when appropriate, we need to take it to the next level. And that's obviously on the client, the consumer, to make that call. My position is to ensure to them, obviously outside of something acute and traumatic that everyone knows to do, right? Bones sticking out of the body. I'm not going to be like, oh, well, you got another set, bro. Let's go.
Yeah.
We know to take them to the hospital.
Let me ask you though, because both of your examples, I think, were good ones in the sense that you promote what we call basically adaptation, right? Or you say so adaptive coping strategies, whereas you have maladaptive coping strategies like fear and anxiety and depression and things like that absolutely play a role in pain. So these are both both. I think the good thing about this post and the good thing that you do is you promote basically adaptive coaching. Like, hey man, look, like you try and bring down the barrier there. Here's what I want to ask you.
Sure.
Let's just say this guy, you manage the load, right? So you went down and you're like, okay, there's no strain, or there's no increase in pain with this activity.
Mm-hmm.
And this post is a little bit more of, okay, well, what if there is? So I just kind of want to talk about that. So let's say this guy comes in and you're managing his load and you drop it off, right? Because he's like, look, I'm at like a 4 or 5, and you're like, okay, well, let's manage the load a little bit more. Let's drop down some. So he feels better the rest of that session, and maybe he has a little bit of soreness that night, but let's not even play that in a role.
Sure.
So he feels a little bit of soreness that day. You modify it. Next time he comes in, it's kind of the same thing. You're not able to progress. He's still having some pain there. At what point do you say, as a coach, what point do you say, well, maybe we stop managing the load and making modifications and I send you on? I just want to know your thought process. That's all.
Yeah. So it comes down to, again, it's going to be ultimately the client's decision because I'm not in that authority, but I'm going to acknowledge progress and healing at every ounce that I can, because if we don't, that's a very slippery slope to go down, of not acknowledging that stuff. And if there's progress and it's moving forward, and like, look, it is less than the last time. We are able to move up in weights, or hey, we are able to increase range of motion, right? If I'm able to essentially create a new progression from I don't want to use the word rehab, but from a stall point to getting back to where we were. If we're making chronic progressions, hey, range of motion has increased from last week. Hey, we were able to add a little bit of weight from last week. Hey, right, if there's one of these factors that are progressing, and we're kind of essentially, I'm no longer trying to push load to the right. I'm trying to push the pain threshold to the right. Is where my realm would be held at. So as long as that pain threshold's being pushed to the right, and things are continuing to progress, and the client is confident, and he or she's not worried or stressed, and we'll keep pushing that to the right until things stop going to the right, or until the client is no longer confident. And usually it's been my experience that the confidence falls off with patience. And then at that point, I'm like, look, by all means, go get it checked out. But it's ultimately not my call. Right now, I have somebody with some bicep issue going on. He's not interested in getting it seen. Adjusted some loads, adjusted some exercises in terms of the adjustments specifically for that were changing the speed. So everything's really tempo based, very modified, just essentially allowing him to use his bicep where there's not pain. And he's seeing some progression from the week to week, and I'm just going to keep working with that until it goes away. Or two, he's like, look, I need to go get this checked out.
Yeah. And here's what I would say, man. I think, I'll give you some credit. You're talking about all these variables, and I think that's really what it comes down to is if you're a coach and you're reading this, you should be tracking load, and you should be tracking whether it's speed or, range of motion. And I think that's something that, obviously if you were here, like I would love to, we would work with the same people, but it's one of those things where I think not all coaches do that.
Right.
It's even an I think, it's an I know. So if there are coaches that are watching this that read this post, I think the harm comes in when the coaches get this information and say, okay, well, if they're having pain with a movement, I'll just modify it. They don't know how to keep themselves in check. And I think for you, and it's not keep themselves in check, it's self-regulate. It's say, you know what, absolutely. Like I need to make sure that I'm monitoring this person rather than just saying, okay, well, maybe just try this instead or try that. And there's nothing wrong with that. I mean, let's say, for instance, someone comes in and they have pretty bad knee pain, say they're not seeing a physical therapist and you guys are doing a lot of squat movements that day. Maybe you go to something that's a little bit more hip dominant. That's a nice adjustment. And then if you go to something that's more hip dominant and it still is bothering them, then I think I think there needs to be some kind of, it doesn't need to be a set in stone rule. I think that's a little much, but I think coaches, give yourself a number, right?
Right.
So give yourself a number of sessions. If you're monitoring the load, and let's say like your example, and they're hitting plateaus or they're getting worse, I think it's really a coach's responsibility to, at that point, regardless of what the patient is saying, because sometimes patient client will say, I don't want to go get it seen, and you're the person they trust. And I think if they're plateauing, not even just plateauing, if they're getting worse and the pain's getting a little bit worse, I think we have to keep ourselves in check and say, okay, now it's time to send you on. Yeah. And I think what this post does for individuals, and I'm not speaking to you, I'm speaking to coaches in general. I think what the post does, though, is it, without a whole lot of biomechanical background, and obviously you have that, but let's just say I'm a personal trainer and I've been out for 2 years and I read this. Well, I don't really, it doesn't mean that all in 2 years do. I'm speaking from my own personal experience. I did not track load very well. I can remember one time where a guy actually had Achilles tendinopathy. I had no idea. I just kind of was like, oh, well, let's just train around it, and had no idea. So I'm speaking more.
Yeah, I think you bring up a really great point. And I'm glad you did, because I didn't even conceptualize it from this point of view. And it's probably because, just my mindset as a coach that I already automatically assumed tracking, right? It's always coming down to progression, no matter what happens. And 9 times out of 10, it's load. But with injuries, it becomes every single modality that I can focus on. And you brought up a really great point just now, is the fact that programs don't exist, right? And I think where this post would be absolutely 100% detrimental, like a terrible post, is a coach who isn't tracking a program, and where they misinterpret what I said, and then they just apply it as in, well, let's just do things that don't hurt, right? And then they just avoid the issue altogether. And when the issue is avoided, now you're not measuring to see if it's getting better, right? If you avoid the issue for a month and then happen to accidentally address it one day and it's completely the same pain level as it was from a month ago, we've got issues, right? I think that's a killer point that you bring up, the fact that if you don't have a plan, like you're not just screwing yourself from a progress standpoint, but when these issues arise of pain and injury and things like that, I mean, you're really setting yourself up for failure.
Well, and I think that's where, if anybody's listening and they've, Aaron and I were talking about, we actually shared a patient last week. And so, well, I'll say patient, let's client. I don't really care for the term patient sometimes. Let's, we shared the same individual, and so Aaron sent him over to me. He was having some crazy like numbness and tingling and things like that. And what really helped me as a physical therapist was I literally had his entire plan. Now, when I've spoken to several coaches or professionals in the past, I say, hey, well, what are they doing? So, well, here's kind of what everybody's been doing, but I'm not really sure what's going on with them. Now, again, not every program can be individualized. I think where it can be tough is in a group setting. And I think that coaches should do their best to communicate with the client, communicate with them, and understand, okay, well, what's bothering you? And sometimes it's okay. Like, right, if they're like, man, I'm having some dull knee pain. I just walked 15 miles yesterday, around whatever.
Let's acknowledge the obvious.
Yeah, and I'm having some dull knee pain. It's like, okay, well, we're doing heavy squats today. Like, you know what? Go to a deadlift instead. Like, let's not push the issue here. I don't really have a problem per se with that example, because I think it's just kind of like, let's not make it more than it is. You walked for 15 miles yesterday, or you did more activity than you're used to, whether it's hiking or I played 3 softball games. They needed me back to back to back. My knees bothering me some. But if you don't track the load, I think that's where this chart absolutely becomes detrimental, because you've got the coaches who, A, are too prideful, or B, not self-reflecting enough to realize I'm not even keeping up with what these people are doing. And it's really hard to do in a group setting, so I'm not knocking that. And I think it's okay sometimes to say, okay, maybe we modify a couple of things. But I think as a coach, and I'm speaking to my 18 to 22-year-old self here, there needs to be a time where I should have said, I need to stop and refer out here. And I think we just have to be self-aware. and just know when that point is, rather than saying, well, this post said if they're 4 to 5, I'm okay. And they didn't really have, and it says to baseline levels within 24 hours. I totally disagree with that. Just by the way, there's times when tissues are really acute, but they may be something that gets inflamed really quick because they have a lot of blood flow.
Right.
And they're going to return back to normal within about an hour or a little over an hour. 24 hours is a long freaking time. Now we're talking more cartilage, right? So it's like cartilage, maybe 24 hours, but it's like it should. And I think they're throwing within 24 hours, it should get better. But I think it basically undersells or understates the fact that, you know what, even if it's an hour, right, that's actually still pretty serious. And I think that's where we have to separate, well, what's irritability and what's actual pain. Right. And in physical therapy, irritability is, well, how quickly can we provoke these symptoms? And irritability and pain don't always go hand in hand. And I think that's a topic for a different discussion, but I think this post is very general. I think the good things are, you absolutely pointed them out. I think it promotes movement. It promotes basically good coping strategies, adaptive coping strategies that people are not, it's not, oh, I need to do bed rest. I think that's good. And I think it gives you some suggestions. I think where it gets harmful, and it could even be with some physical therapists, there are certain things that should absolutely be loaded and you should use this chart for. Achilles tendinopathy, for example, Achilles tendinitis. Manual therapy and all those things, while they're good and can address contributing factors, guess what the best thing to do is for Achilles tendinopathy? Load it. Yep. So if you can use this, then absolutely, that's where it's applicable. But I think it's a very general statement. But then it's like, okay, well, what about, I don't know, plantar fasciitis, or what about something else, right? What about some other kind of issue? And I think that's where I think we can overgeneralize it. Overall, a good post, but I think, in Jeff Moore, in that post that I kind of tagged you in, it's like you have to turn around and you have to look at it the other way. Yeah. And I think we assume that everyone's tracking load, because we're like, well, I track load, or I keep myself in check, and sometimes it's just not the case. So that was kind of my biggest problem, is I think it just overgeneralized things. Had some good things, had some bad things, but
yeah, I think one more point that we need to address on it that just came to mind. This kind of an irritable subject for the both of us is when you're not tracking a program and there's exercise being done, and this happens a lot because I think it's amplified because of other posts that are quick posts in terms of exercise selection, and it all makes sense in a minute. But somebody will get injured, and again, it's not on a program. They just happen to get injured or go through some pain, and so they shotgun blast exercise at them, and they got injured. How? Who knows? Because it was shotgun blasted. So their response is, as a non-medical professional, as a trainer or coach, is to just shotgun blast a bunch of rehab PT exercises that they found and say, oh, well, you got knee pain? Well, here's 1,500 rehab exercises that cover it. And then they just talk about, again, they're not tracking or progressing anything. They just it's a reductionist mindset of, hey, you have knee pain, here's a knee pain exercise, so just do this till the knee pain goes away. Well, you just completely missed the point.
Well, and I 100% agree. So and I think even looking at this, right, you guys can't see this because it is way too bright. So, and most of this stuff is good, but I think the problem becomes it's so accessible that as a coach, if you're not really holding yourself in check, you start doing a bunch of things that you have good intentions. And I think most people have good intentions. But I think what happens is you get into this thing where, let's say low back pain, right? And you say, well, I saw these 3 exercises for your low back pain, or what you think is going on as far as, well, I think, oh, you've got pain down the back of your leg. It's sciatica, so do these stretches. Yeah, not all the time. Well, you've got low back pain, so let's do these exercises. Not necessarily, right? I mean, McKenzie approach, well, it works for some. And when you dial it in and you know what you're looking at, sure, it may work for them. But some people need to go the complete opposite direction. Some people need to be loaded. Some people need to go into a mobilization protocol or mobilization program. And I think that's where the accessibility of the information sometimes can be harmful, is knowing when to apply it and knowing if you're the right person to apply it. And I think that's where I think you can keep yourself in check because you've been doing it long enough, and you're like, I know what I know, and there's certain things where it's like, oh, this is good for information, and this is good, and I can learn from this, and I can totally apply it.
Yeah.
I think sometimes though, like this one, rotator cuff isometrics on the wall. Well, that's great, but I think if you are a coach and you're saying do these isometrics because it sounds like you've got a rotator cuff tear, then I'll just tell you ignorance is bliss. You probably have no idea if it's a rotator cuff tear or not. And I think that's where we can get into trouble with it. And I think, again, I think we both agree that this is on a spectrum. Like, I think there's a place for both. And I'm not knocking any coaches because I talk to you all the freaking time and bounce ideas off of you. And I think you're good at what you do. And I think we just have to reflect. And this is as physical therapists too. Don't get me wrong. This post, if a physical therapist is reading it, with the wrong pathology, if you have diagnosed the wrong thing or you have not looked at the big picture and you said just keep pushing through it, that's a problem too. So I'm not, and I know it sounds like I'm more picking on coaches because we're talking more some load management and things like that, but physical therapists, you should absolutely be looking at load management as well, or else you're doing a disservice to your patients. I mean, you should be tracking information. So
I think that brings up another great point that you brought up is like, look, what's the difference between rehab and a strength program? And essentially the only difference was the starting point. They both are progressing. They are both on a titrated system of managing and tracking everything. And so rehab and strength and conditioning have the same concepts, and then also the abuse has the same abuse, right? We shotgun blast exercises. Somebody gets hurt. That's wrong to shotgun blast exercises, and then it's also wrong to shotgun blast rehab exercises, right?
I 100% agree with you. I think and physical therapists do it all the time. I mean, I literally, and I'll tell you, I can't say where or who it was. I sat and I watched 3 lower back pain examinations. All 3 got the same exact exercises. All 3 got single kneaded chest, double kneaded chest, and lower trunk rotations. All 3 with different exercises or different presentations. All 3 different ages and different comorbidities. Again, this is not to pick on coaches. This is just to tell everybody, look, like, yes, the pain, like keeping track with that, but you have to do a good job of self-regulating and self-managing, because if you shotgun approach an exercise prescription, whether it's rehab or afterwards, well, how do you know if they get any better, and how do you know if they get any worse? Or you shotgun approach, let me just go ahead and drop this one down. If you shotgun, you say, well, I'm going to do some cupping and some dry needling, and then I'm going to manipulate them, and then do some soft tissue work, and they come back in and they feel better. Well, that's great. I'm glad you got them better, but what made them better? Well, I don't know. I'll just keep doing the same thing.
That's the issue is one, shotgun blast, they don't improve, or worse, shotgun blast, they do improve, and then you give credit to 6 things that shouldn't take credit, and now you're pushing that agenda out there.
You know what I think makes a really, and I have not been out long enough to really speak truly to this, but I can just say based on what I've heard from other people, what makes an expert physical therapist, and I think that's constantly something we're all chasing, but what makes an expert different than a novice is the expert does the simple things well and keeps it simple. I mean, I think it's just, I don't think it means, well, they're just going to do one stretch and that's it. But when you're getting into, it's an educated trial and error. I mean, essentially is what it's, hey, I'm not going to cup, dry needle, and manipulate, and do soft tissue, and give them an exercise. I'm going to adjust this and adjust that and see how they respond. Because when they come in next time, oh, well, you know what? This is what we adjusted. This is the only thing we added. We added one new exercise. They're in more pain. We didn't change anything else. Same principles apply to both fields. And I think there's people in both that absolutely do it wrong. And I think that's where this post could be troublesome. But no, 100% agree with you. You cannot shotgun approach something, especially guys, if you're doing an individualized, any physical therapist, you should be doing individualized programs. And then coaches, if you have the opportunity to do online coaching and do personal training or personal coaching, I mean, absolutely, like it should be individualized. You should not have the same people doing all the same stuff. It's not to say that there's not good exercises that can be applied to multiple individuals, but each program should be tailored and monitored individually. So
definitely. Awesome. Yeah, that was definitely a really good discussion. We'll we'll try and get Dr. Burgess to listen to this one, huh?
Well, I mean,
That'd be interesting.
He's definitely got the credentials. He's
Yeah.
CSS, he's OCS. He's kind of a good what's good in both worlds. But I would be interested to know, like, I think we think we're doing so much good with putting all this information out there, but I think we have to turn back around and say, can some of this be harmful? Should I don't. It's so hard to monitor it. It's so
Right.
hard to monitor it, But I think we do have to at least be aware of what's out there and what could be modified and not, and just take everything as scripture, right?
Right. Yeah, that's the biggest
Every
thing.
physical therapist says, every physical therapist with over 20,000 followers has to know what he's doing. Every coach with over however many thousand people have to know what they're doing. Not necessarily. So it doesn't mean that there aren't good intentions, but I think we have to reflect on these things if we want to make sure that our clients get better and we're smart about it. So that's just my 2 cents.
Yeah. Yeah. Either way, good post for good discussion. And yeah, I was glad to hear it. Definitely brought up some really good points. So
I hear you, man. Well,